My name is Christine Amoroso, and I'm a nurse at Fox Chase Cancer Center in Philadelphia, specializing in urologic oncology. I've worked at Fox Chase for the past 37 years. In addition to urologic procedures, I administer intravesical bladder treatments in our nurse-led bladder treatment clinics. We treat approximately 50 patients per week. Traditional treatment is surgical resection, followed by intravesical or systemic chemotherapy or biotherapy. We encountered several patients with upper tract urothelial carcinoma. This is disease in either the kidney or the ureter. Urothelial carcinoma is an uncommon diagnosis and one in which traditional intravesical therapy may not be effective due to the location of the involved tissue. Instillation of medication into the bladder via catheter may not reach the level of targeted tissue. The urology physicians here at Fox Chase wanted to treat these patients with upper tract disease using an antegrade approach via percutaneous nephrostomy tubes. The issue the clinical nurses encountered is that there is little published information about administration of intrarenal infusion for nurses. Because of this, the urology nurses here at Fox Chase formed a multidisciplinary team consisting of physicians, pharmacists, and clinical nurses to create an evidence-based protocol for the safe administration of intrarenal medication, in particular chemotherapy or BCG. We have treated patients with unilateral disease, but also bilateral disease requiring bilateral nephrostomy tubes. There are many important points to be considered for protocol development. These included, but not limited to, the timing of PCN placement to the start of treatment. PCN is placed 1 week prior to start of treatment in our interventional radiology department. Patients are admitted overnight in the hospital for observation per our policy. The safe rate of infusion needed to be considered. We infuse over 1 hour via gravity. We also needed to consider safety measures to avoid increased intrarenal pressure during the infusion. IV pumps are never to be used, as this would cause too much pressure for the kidneys. Infusion must be via gravity. Also, our urology office is at an ancillary location to the hospital. Our infusion pharmacy is located at the main hospital, a few blocks away. This had to be factored into our treatment timing, as BCG is stable for only 2 hours once reconstituted. It needs to be infused within that 2-hour window. Our pharmacy decided that they would spike the IV medication bag prior to sending it to our clinical unit with the tubing primed under the hood in the pharmacy for added safe administration of chemotherapy. We utilized a courier service that needed to be coordinated for proper timing of delivery from our pharmacy to our unit. The medication delivery system, the IV bag, is to be hung 10 inches from the level of the kidney to avoid increased intrarenal pressure. Medication dwell time in the bladder needed to be thought about. We infuse the medication over 1 hour. Then we have the patient hold in the bladder for an additional hour before voiding. This allows for the recommended 2-hour dwell time that we follow for our intravesical BCG. The proper flushing prior to and following infusion is determined by the treating physician on a patient-to-patient basis once the PCN is placed. Patient education is critical. We met with the patients for a one-on-one teaching session prior to the start of treatment to discuss the schedule. This included explanation that treatments are once weekly for 6 weeks. We taught PCN flushing and site care, the signs and symptoms to report before and during treatment, the timing of PCN removal following completion of treatment. Typically, the PCN is removed 1 week after completion of treatment in the interventional radiology department. We taught and ensured patient understanding of pre- and post-treatment instructions. We encouraged each patient to have someone accompany them to the teaching session. We encouraged the patient to have someone come with them to their weekly treatments, as they would be lying for 1 hour, and it's nice to have company. And as a side note, we treated our first patient during the height of the COVID pandemic, so close communication with the multidisciplinary team was very important, as many team members were off-site.